What I'd like to do today, this morning, is talk a little bit about Dogma. This is important to me because Dr. Desai and I were just chatting before the symposium this morning about how different neurology is today from when we started. We have so much more to do in all of neurology, but especially in stroke neurology. And there's new data confronting you every week, it seems. There's a new paper or a new technology or a new medication. So I'd like to talk a little bit about how we should maybe, or how maybe I think about new data and what to believe and what not to believe. I do have a couple of disclosures. I am supported by these NIH grants. I don't have any industry support, but I do have the book, which is still for sale online if anybody's interested. And I found this picture of Dogma, and I love this picture because there's this old man, which I'm becoming more and more of, pointing to the book, telling the student, and he's holding the student by the back of the neck and saying, "This is what you need to believe right here." And I feel like so much of our field, when I started, neurology was defined by the older men telling us, this is a stroke, this is where the brain, this is how the brain works. This is a stroke because I said it was. And then we got CAT scans and realized maybe these guys weren't right all the time. And then we got MRI scans and learned a whole bunch more things about how the brain works. So I want to go through a couple of examples. Now, a lot of you take care of critically ill patients or even outpatients, and you're familiar with the autoregulatory curve. You know that as blood pressure changes, this is actually the PaCO2 autoregulation curve, but it's the same idea. As blood pressure changes, blood flow stays the same, except if the person has chronic hypertension. And then the curve is so-called right-shifted. So you all know to be careful when you lower the blood pressure in a patient with chronic hypertension. And so this is Dogma. This is something that we teach. You don't rotate in an ICU longer than 5 minutes before someone is teaching you about the autoregulatory curve. This is the one that goes with the arterial blood pressure. So if you drop the blood pressure below a certain level, blood flow goes down. In fact, some of you who work in the neuro ICU now use pressor therapy to raise the blood pressure sometimes to improve blood flow in some patients. And so for a variety of reasons, I got interested in, well, where does this come from? Where is this science? Where's this data come from? And this is it. This is the data. So there's 3 normal patients right down here. And this is one of those experiments that could never, ever be done again, right? These are volunteers who voluntarily laid down on a table, and their ability to regulate their blood pressure was paralyzed, and they were tilted until they became unconscious. It's a true story. And so we're not going to repeat that because medical students won't volunteer anymore. So down here are some normal patients, and you can see as this patient's blood pressure drops, his blood flow does start to go down. He doesn't do the up part, this patient does. But these are 3 normals. Now these are 10 patients with chronic hypertension. And you can see this one up here, case number 1, kind of follows the Dogma, sort of. So he's right shifted and he loses blood flow at a higher level than the 3 controls. But the other guys don't exactly follow the right textbook picture. But the point is, this is it. This is all the data there is for this clinical dictum about the autoregulatory curve and the right shift. Now, is it true? I think it is true because we all behave this way. We treat patients like this is true, and it works. So this is kind of an example of a dogma that's based on very little data, but we all kind of use it and it kind of works, and it turned out to be okay. Now I know what you're thinking. Don't tell me the penumbra isn't real, right? Because we live and breathe the penumbra, right? This is our life. Because the penumbra exists, we can give TPA and do thrombectomy and people get better. I got some bad news for you. Here's the data, all right? This is the original paper that was published in 1977. They're summarizing experiments done in primates. And the numbers here refer to the median blood flow and the standard deviation. So in the core, what is going to become the core, blood flow was 48 with a standard deviation of 12. And after the occlusion, it went down to 12 with a standard deviation of 6. So, Pat, what's your problem? Looks okay, right? This is true, but what is missing from this, so you see before occlusion, we have 10 animals and 29 electrodes, and after occlusion, we have 8 animals and 23 electrodes. Between the baseline and the occlusion, 5 animals disappeared. They were excluded from the data. And the reason they were excluded is because their electrodes showed normal blood flow, okay? So what is true about the penumbra is that it's heterogeneous. It doesn't look like, this is called the shell model, all right? So it doesn't look like that. It's actually islands, patches of blood flow. And I published this idea a long, long time ago. No one thought that that was true. But there was a paper just recently looking at blood flow and looking at blood flow maps showing that the penumbra really is islands. So this is an example of dogma where our model's completely wrong, but it doesn't matter. Because in the end, the core enlarges, whether it's a shell model or an island model, it actually doesn't matter. So we can safely ignore it and pretend that the shell model really is true. And so this is the shell model, the so-called island model. After stroke, there are islands of penumbra and then the core. But it doesn't matter. So this is an example of dogma that we can safely ignore. Well, now what about this dogma? We are used to looking at the angiograms we get out of the rapid scanner or out of the CTA, and we look at that occluded MCA. And if you've ever been to the International Stroke Meeting, you've heard talk after talk after talk. And the speaker always says, that will never open. I wrote it in yellow. That occlusion will never open. That will never open. And here is the angiogram afterwards. And the thrombectomy doctor says, look what I did. I opened that artery. Except this picture right here is IV TPA. This is a patient who got IV TPA, not thrombectomy. So how often does that happen? It actually happens a reasonable amount of the time. So in patients with any occlusion, 33% of them open up. With patients with an M1, a proximal M1, 35% of the time they open up on their own without thrombectomy. M2s, a little bit more often, 52. And look at this, the terminal ICA, the one that everyone says will never open by itself, 13%. So this is dogma, the idea that an M1 will never open without thrombectomy. That's really important to keep in mind. This one really matters. It is not true that that artery will never open without a thrombectomy. Does the thrombectomy help? Absolutely. Does it improve the outcome? Absolutely. But it is not fair or true to say without the thrombectomy you have no chance. That is not the case. Thrombectomy works, but there is a fair amount, 13% or 35% of patients, that will open up with IV TPA alone. This one here turns out to be crucial. This one is the most important. If you've ever heard about lacunar strokes, you've heard them called small vessel strokes. Small vessel strokes are caused by intimal hyperplasia, cystic medial necrosis, and Dr. Miller-Fisher published this paper, and I had to memorize this when I was a medical student. Small vessel strokes are caused by intimal hyperplasia. Now, Dr. Desai told you in the introduction that I was part of the group that wrote the protocol for the TPA study, for the NINDS TPA study. And when we were writing it, we were told by our elders, now go back to that picture in the beginning, those guys, okay? They said, don't put the lacunes in the study. Don't try to give TPA to lacunar patients because they are due to an intimal hyperplasia. There's no clot. So a thrombolytic makes no sense. That was the dogma. And we were young and stupid and didn't listen to our elders. And so we included the strokes, the small vessel strokes, the lacunes in the study. Now this is data that has never been published, but it's from the original study. It's from the NINDS study. And it shows the amount of people who got a Rankin of 0 or 1. So Dr. Desai showed you Pomona Valley Hospital outcome, which is amazing outcome, Rankin 0 or 1, that means a cure. So this is Rankin 0 or 1 for TPA-treated patients or placebo-treated patients. Now look who did the best. The lacunes. The lacunes did the best because the dogma is just wrong. The dogma is wrong. There is intimal hyperplasia, but what causes the lacune is a small clot in that artery, and TPA opens it up, and TPA works best for lacunes. Now, I don't want this to go any farther, all right? This is just between us. If you take these patients out of the data, take away the lacunes, this data over here is not very statistically significant. In other words, the original trial that showed TPA worked would have failed. If we'd listened to the dogma, that study would have been negative. Now, clearly it works. It clearly works for all types of stroke. Don't get me wrong. It works for large strokes. But we would have needed more patients to show the benefit. The study would have been underpowered without the lacunes if we had listened to the dogma. So this is an example where dogma being wrong really has a bad outcome. All right. I wanted to say a little bit about thrombectomy. I think you all know the 4 big trials that were published a few years ago that show benefit of endovascular. They were slightly different in terms of their timing, as Dr. Desai showed you. I love that 3, 4.5, 6, 18, 24. And then whether they allowed aspects of what various scores. And here is the meta-analysis of the studies, of all of the thrombectomy studies, looking at patients who did not get TPA or who did get TPA. And this is a little dogma that's been filtering around, and some of you may have heard it, some of you may have not. But there is a school of thought that we don't need to give the TPA, that we can just do the thrombectomy. Why stop in the ED and give TPA? Let's just go right to the thrombectomy. And the data here does not suggest that. The data here suggests that doing both where the patient needs both is superior. And I want to ask for your help in sort of being the ones who raise a hand and say, is that really true? When someone says to you, we don't need the TPA, we just need the thrombectomy for the reasons that I've shown you. This is a very important slide that says we don't have 18 hours. We don't have 24 hours. The next time you're at a stroke alert and the family says this started 6 hours ago, and the team all relaxes and says, oh, 6 hours ago, we have 24 hours, right? That is not true. You have 1 minute, because every minute that goes by, you lose probability of helping that patient. You lose likelihood of a cure with every minute that goes by. So there's no 24-hour window, there's no 18-hour window, there's 1 minute. This patient's in front of us, we want to get him to the scanner and then to the thrombectomy as quickly as possible. I love Dr. Desai's opening slide with the clock and the brain. And we now don't even worry so much about the clock, we worry about the brain. And we do the imaging, thanks to the DAWN trial, the Diffuse trial, and the Wake Up trial. We know that if we select patients for thrombectomy based on their imaging, based on their penumbra, that we can save more people later. And so thanks to imaging-guided selection, we're able to find patients who arrive late or wake up with their stroke. This is the picture that I said was wrong, right? This is the most important thing about rapid that you should take away is these colors. These are painted, right? The computer paints those colors. That's not real. The green is not the salvageable brain. It's paint. The pink is not the core of the infarct. It's paint. But it's been shown over and over that these numbers help us decide that a patient has salvageable brain, right? It works. It's not correct, but this is that dogma that it works. We know when there's mismatch and we treat the patient, they are potentially salvageable. And this is the Diffuse 3 results that showed if you use imaging-guided selection, you get a significantly increased benefit with endovascular therapy compared to TPA alone. All right, the last dogma I want to walk you through is my favorite. We're going to look at the new anticoagulants. And those of you that are my age are farther away from the clotting cascade than those of you that are still students. But we all have to memorize the clotting cascade. We all have to pass a test on it, and then we forget about it. Except when these novel oral anticoagulants were invented, we had to remember that factor 2 is prothrombin, and factor 2A is thrombin. That's the activated factor 2 is thrombin. And it is factor 10 that is activated to convert prothrombin to thrombin. So activated factor 10 converts factor 2 to 2A, which means 10A converts prothrombin to thrombin. And so we have 10A inhibitors, apixaban and rivaroxaban, and we have direct thrombin and inhibitors, dabigatran, that bind right to the thrombin. And those are our new agents. They've replaced Coumadin because of this data. So this was the first one looking at patients with atrial fibrillation and giving them Coumadin or dabigatran, and the direct thrombin inhibitor, dabigatran, was superior. The curves here show lower rates of stroke compared to warfarin. Then came along apixaban, and apixaban showed the same thing. Apixaban has also been shown to prevent pulmonary embolism, so we like it for DVT patients, but a significant lower risk compared to aspirin in this study, but the same experiment with Coumadin shows apixaban to be superior, and then this is rivaroxaban, so compared to Coumadin for atrial fibrillation, but also for DVT prevention. So this is the meta-analysis looking at all of the trials put together and comparing them to Coumadin, showing a clear and persuasive effect on mortality, major bleeding, and reduced stroke. Now why does this work? Why do these drugs work? Well, it's obvious. They're blood thinners, right? They're anticoagulants. So the idea is that during a stroke, thrombin is activated. It activates the coagulant cascade. This causes microthrombosis, so-called microthrombosis, which causes vascular and tissue injury. So obviously, if we block coagulation with these anticoagulants, we'll improve perfusion and the patient will do better. Except that's not true. These are studies looking at anticoagulants, and I purposely made the table so big that you can't see the individual trials because I want you to see how many patients were treated with anticoagulants. Heparin, heparinoid, dalteparin, tenazepam, all of these blood anticoagulants, very large treatment trials looking at stroke, trying to make stroke patients better with anticoagulants, and that's what happened. Nothing worked. It didn't work. Anticoagulants do not improve outcome. We don't give heparin for stroke anymore. I don't think anybody is old enough to remember the days when heparin was the only treatment for stroke and every stroke patient got heparin because Dr. Miller Fisher in Boston said so. It was the dogma that you gave heparin for stroke, but when you did placebo-controlled trials, it never worked. So this is the alternative to that dogma. During thrombin activation, thrombin acts on the so-called thrombin receptor, and the thrombin receptor kills the cells, all right? Thrombin actually kills cells. Thrombin acts on its own receptor, which is called the protease-activated receptor, and this is why we think some of the thrombin antagonists are better drugs than heparin or other anticoagulants. So the theory works like this. In the neurovascular unit, you have astrocytes, neurons, and you have the capillary here, which is surrounded by the endothelial cell and the pericytes. All of these different cells work together in what's called the neurovascular unit. And the astrocytes and the endothelial cells create what's called the blood-brain barrier and protect the brain from thrombin and other toxins that are flowing through the bloodstream until there's a stroke. And then this blood-brain barrier opens and thrombin floods into the brain and starts to kill the cells. So we did this experiment a long time ago in my lab, and we showed actually thrombin adherent to the neurons. This is, the red color is thrombin actually staining neurons and not staining some of the other cells. And that led to our exploration of how all this works. Now here's where it gets so cool, because the thrombin receptor is called protease-activated receptor, PAR1. Now check this out. Here's this extracellular tail sticking outside of the cell. Thrombin comes along and lays down on it and clips off this little piece, this little tiny piece. And this tail right here is still on the PAR1 molecule, and it flips over and binds to itself. And that's why the cell is killed, because the thrombin cuts off this little piece, and the receptor itself is activated when this tail flips over here. Now, guess what? This little cleavage spot right here attracts a different molecule called activated protein C. Activated protein C, APC, clips off a different tail right next door, 4 amino acids away. And the little tail flips over, and when that happens, the cell is protected. So one enzyme clips off the tail, the cell dies. Another enzyme clips off the tail in a very slightly different place, and the cell is protected, all right? And in the interest of time, I will not fill you in on all the cool details about why we know this is true. I will ask you to take my word for the moment, but then check out the papers. This is true, and therefore, we did a study of activated protein C as a neuroprotectant, not as a blood thinner, but as a neuroprotectant. And the drug is called 3K3A APC because it's been slightly modified to make it work better in humans. We did this trial called Rhapsody, where we looked at 3K3A for strokes. It was a dose-finding study. So we had 110 patients, and 66 were randomized to get the 3K3A APC. 44 got placebo. We were using a bunch of different doses. The sample sizes are different because we were using a dose escalation algorithm. And this is the final data. It's all published. You can check these numbers out, but I just want to highlight, I'm picking the best ones, all right? In all fairness, I'm picking the best ones. So when we looked at the results, brain hemorrhage occurred in 76% of patients, which was 67% patients who were treated with APC and 86% of patients who were treated with placebo. So borderline, 0.05, right on the border of statistical significance. When we looked at total hemorrhage volume, how big the bleeds were, 0.8 compared to 2.1. So basically a 50% reduction in the size of the hemorrhages. So what happened is the APC cleaved off that tail in the cells that make the blood-brain barrier, the endothelial cells, and protected the brain during TPA from hemorrhage. So you had fewer hemorrhages because of that protection effect of the blood-brain barrier. Now this molecule also protects the neurons, but it reduced the bleeding because it protected the cell. This is an anticoagulant. This is a blood thinner, and it's reducing hemorrhage. The opposite of Dogma, right? The opposite of what Dogma tells us. Argatroban is the blood thinner that you use when the patient has HITS, heparin-induced thrombocytopenia. Argatroban is a blood thinner. It's intravenous dabigatran. It binds the thrombin, it inhibits the thrombin, and it reduces hemorrhage. It reduces hemorrhage after TPA. In this experiment, which is called the ARTS trial, we gave argatroban plus TPA, and we ran the PTT up to 1.75 times control. So we anticoagulated the patients, we raised their PTT, and they had fewer bleeds. So the next time you're in the ER and a patient comes in and says they're on dabigatran or apixaban or Xarelto, you're supposed to say, we can't treat you with TPA because you're on a blood thinner. That's what the guidelines tell you to do. That is dogma. That's wrong. That is wrong dogma. Now, right now today, you got to follow the guidelines. All right? I'm not saying don't follow the guidelines. All right? You got to follow the guidelines. But if they're on dabigatran and their coags are normal, we treat. So if they have normal coags on one of these novel anticoagulants, we do treat. And this is the results of the ARTS trial, just showing that with that argatroban, the patients did better. There's a study coming up called MOST, which is going to definitively look at argatroban versus placebo versus eptifibatide. So this is Giordano Bruno. Giordano Bruno was a monk who in the 1600s was burned at the stake in Campo de Fiore in the center of Rome because he said things that the old guys didn't like. One of the things he said was, is it possible that we don't yet know everything? And the people that were paid to tell you that they know everything burned him at the stake because he said, we might not know everything yet. He also said, truth does not change because it is or is not believed by a majority of people. So my point being that I think it's wise to take data, make decisions, follow guidelines, but it's wiser to ask, where does the data come from? Can we really believe it? And is it sound? And is it based on actual facts? Or is it because someone told us this was the way it is and they don't really know? So I really appreciate the opportunity to come speak with you today. Thank you all very much.